Good evening, everyone. Here Imran Abbas. Again, I am live. I am live from Dubai, and today we are with Professor Bruno Dillemans. He is really a live legend. There is no doubt, and this is my dream. This is really my dream to interview such a prestigious figure, such a great surgeon. Because my viewers, this is the reality that today, when we will be with Professor, at least we are 5 years ahead to text that maybe in future, so we will write some papers, then it will be the text. Now we have this opportunity. We hear live from Professor Bruno. If you have any question, you can ask question. Sir, I will not take your time. Sir, please, over to you.
Thank you very much, Imran. Back again for this, I would say exquisite invitation to be present back again on global laparoscopy and robotics. All my congrats has to go to you. That I was just saying that you proceeded with that initiative, and that now you can see that the success is increasing, which is certainly not have been from the start. And back again, the continuation of such a program, I think, is critical. So everybody could learn a bit of all those interviews that you have. And back again, as you presented me as a living legend, that's probably a bit too exaggerated. But anyway, we try to do our best. And at a certain level, we got more and more experience. And it's also due to those interviews that you could have, but also to have showing live surgery that a lot of younger surgeons who are willing to make the step into more advanced bariatric surgery or complex bariatric surgery, revisional bariatric surgeries, that those issues, I think, are imperative, are very important. So for that thing, thank you very much. You asked me as well, what is my experience? Very briefly, I am a general surgeon, which have been accredited in 1992, a long time ago, a bit too long time ago. So we started with oncologic surgery. And then at the mid-90s, I was becoming a bit more and more interested for the bariatric surgery. Initially, it was to lose weight solely. There was not a real metabolic component on it. And so we were keen to start with what we call nowadays the pure restrictive procedures. It was the laparoscopic band. And also in our country, as well as I think in France, in Italy, quite a lot of VBGs, vertical banded gastroplasties, according to Mason. Later, it has been adjusted to McLean. It was a completely laparoscopic version, etc. It was a nice procedure. I did around, I think, 1,500 procedures, as well as bands. But then, I think in 2004, I got so much involved that I had to leave the oncologic surgery. So I took two other good surgeons in my team, one for the colorectal surgery and one for the esophageal cancer surgery. And then I jumped completely on the bariatric field in 2004. And since then, we have to say, frankly, that there was a sharp increase in total numbers that we could operate. I had the advantage that I was quite well trained laparoscopically. I was in front of the laparoscopic evolution at the end of the 90s, which gives me a bit, I would say, an advantage towards the older surgeons who were still operating by open access. And you all know that laparoscopic access nowadays is, I think, an essential part of the success of the bariatric surgery. So I started then in 2004 doing the laparoscopic McLeans, etc. And then I jumped into the gastric bypass. Initially, it was open retrocolic, retrogastric, but then also, I think in 2004 already, at the end, I went to the laparoscopic gastric bypass, anticolic, antigastric, a bit more easy. And then, it was a really very sharp increase. So the pure restrictive procedure were decreasing. I would say in interest also because the results were not so splendid and there were quite a lot of complications, mechanical device related for the band, but also for the VBG, gastric outlet obstruction. And the bypass was the better solution. But before that, it was all by open access. Patients stayed 10 days in the hospital. Nowadays, they stay just one night in the hospital. Could you believe that? And a bypass takes around 50 minutes to proceed. The classical Y one. And so then it evolved very sharply, I would say, both in volume, as I think, both in quality of surgery, because more and more we get referrals for doing revisional surgery. Patients who got the band previously without good success, VBGs, also from own institutes, we have to say, but also then bypasses, you had weight gain, and also sleeve gastrectomies, because the sleeve gastrectomy has never been that popular in Belgium or in the Netherlands or in the Scandinavian countries. It's now picking up, and I think nowadays around 25% of the primary procedures are sleeve gastrectomy, but it's certainly not that volume or that percentage that we see in the United States or in Australia, all the parts in the world. I think that only in Latin America, still a bit the gastric bypass is the preferred primary surgical solution. But anyway, you can see that we evolved a bit, but still a bit of bypass of the primary procedure. But we have seen also a radical change in type of revision surgery that we're doing nowadays. In 2009, I looked to my figures, 95% of the revisional procedures were conversions from a band or VBG, mainly to a gastric bypass, rarely to a sleeve. And now, just 10 years later, the year before the corona, 2019, 50% of the patients that were operated for weight gain were patients who had a so-called unsuccessful gastric bypass. The sleeve is now picking up as well because the total numbers were not so high in Belgium. But that has been just in a time leap of 10 years, a radical change. So nowadays we do around 4 revisions. Let's say, yes, that we're going to discuss it a bit later, revisions for patients who got weight gain after gastric bypass on weekly basis. So that's a high number.
Sir, excellent, really. And this is a brief introduction. And definitely, we are talking with someone who has experienced more than 2 decades, and also as well as we can talk about also this restrictive to any malabsorptive, as well as we are talking about hybrid to hybrid, malabsorptive to malabsorptive indication. But then overall, as sir, you know better than me, obesity is multifactorial, and surgery is not definite treatment of
Not the final
obesity. Not,
solution, 100%.
now, as you have mentioned, yes, as you have mentioned, till bypass, now we, yes, yes.
100% true. The only thing is that in a lot of countries nowadays, like still in the United States, that's a bit a pity, that revision surgery is still not always accepted to be funded, like in a lot of US states. That's one of the reasons that Harry Buchwald, everybody knows a bit Harry Buchwald, stated in 2 nice editorials in 2004, both in obesity surgery as well as in SWORD, that performing revisional bariatric surgery is a moral obligation. And renouncing this hard step that we gained is going back to the past where there's no issue for that. That means that if you have a patient with weight gain, we have to defend a bit that obesity is a chronic disease. Nowhere else in the spectrum of medicine is a patient denied remedial or revisional care. You understand what I mean? But still in a lot of countries, it's like you got for a bariatric surgical procedure, you just got one chance. But since 2004, obesity is accredited, if I may say so, as a formal disease. I think in 2004, but it's a chronic disease. So on that part, I think it's very important that we have to accept also. We know that there is certainly also a patient-related factor, but also regardless of that, you could have patients who have lung cancer who did a recurrence. Are you going to say no, because it is mainly a self-inflicted disease by smoking? No, you still can consider to go for remedial care or whatever salvage care. So on that part, happily here in Belgium, we have a relatively good system, but in a lot of other countries, just one operation has been funded and not a second one, which I think is completely incorrect.
Sir, as you have mentioned, definitely this will be also a message for our youngster. So treatment of obesity need MDT. This is not only the role of surgeon, unfortunately, in many countries that we are living here. So just they think about this, we will do a sleeve, we will do just gastric bypass with, I don't know, long BP limb, something. No, this is multidisciplinary team. The role
100%
of
true.
multidisciplinary team is more important, not only surgery. As a message from a legend, as Professor Bruno. Sir, how you define, because these are some repeated questions. So revisional, we also see this is the conversion. We also see, so yeah, please, if you highlight.
Corrections. And at last also reversals. Reversal is also undoing your procedure. Now, the revisional bariatric surgery procedures are the completely whole of group of surgical procedures. For weight gain or for complications, etc., where you're going to try to modify the primary procedure or to correct it. Conversions means that you're going to change the index type of surgical procedure to another one. You go for band to bypass, band to sleeve, that's completely different. That's a real form of conversion. A correction means that you're going to do a correction of that initial anatomy of the procedure. If you have, like, say, a patient with weight gain after bypass, and you're just going to solely do a pouch resizing, then it is, by way of speaking, corrective surgical procedure. If you're going to do a re-sleeve, you understand, because the fundus have been left too redundant, it's more a corrective surgical procedure. Reversals, that's also one of the three terminologies under the umbrella of revisions. Reversal error, where you're going to undo your procedure, undo of a bypass or undo whatever procedure, where you're going to try to restore the anatomical integrity as it was before the index procedure. That's a bit the classic terminology that we have to use. Revision is always good, you understand, because complications are also included. But a lot of, I would say, conversions are done purely for weight gain and not for complications, for sure. But revisional is the big group.
Sir, we always, so now we are little talking about a case, a patient with weight regain after standard sleeve gastrectomy. Standard sleeve. That was standard sleeve gastrectomy. And also now after 4 year, 5 year, 6, that is the natural. So patient consult to you with weight regain, that now there we know, yes, patient touch this, now patient BMI is more than 35. 32, 33, 35, and also there is also some comorbidities as well. We can see reoccurrence or relapse of diabetes in this patient. So we will go for MDT, we will go for dietary protocol, everything okay. So what is my question? How you can see endoscopic role is, we can go first MDT and this just like dietary habits, and so we can use some medicine.
Yep. You have to do, surely, first of all, I think, a good evaluation of what is at stake for that individual patient. I think it is critical. And that's a good message, I think, also for the gastric bypass patients with weight gain. We do more than in other institutions, a daily caloric measurement. We ask it for the patient. So we ask to our patient to really write down everything. There is a bias, but we try to exclude it on weekly basis, everything what they eat and drink. They have to measure that, 120-gram chicken, whatever, 40-gram potatoes. They write it down. And then it takes 1 hour, 1 hour and 50 minutes for a nutritionist to do that calculation. So at least we know a bit what is the total volume of the caloric intake that the patient is eating. And I was amazed to see in a nice study that have been performed to look into for the systematic review of the etiology of weight gain for a bypass, that in most papers, they don't do that. Just in 3 papers of 41, that was a study from Carmen Saravia, I think, from Iran, who does a lot of nice studies. Just 3 studies of 41, the best studies for weight gain after bypass, were mentioning regarding some, I would say, behavior change that happened for the patient. But if you don't do that, you don't know what you have to offer your patient. We have patients who had a sleeve or a bypass who are eating like a gorilla. They eat 4,000 kilocalories a day. So it's, I think, imminent that those patients have to be forced to the dietitian. You know, it's not allowed to eat that amount. And I'm amazed to see. But if you have a patient who is still quite well compliant and is eating 1,400 kilocalories a day, that's going to change your surgical or medical strategy. I think this is important. That is just one issue. Doing a good daily caloric intake. The next thing is, for sure, do good radiological and endoscopic evaluation. As you mentioned, for that, for a sleeve, let's say, is it a primary non-responder? Is it a secondary non-responder? How is the volume of the fundus leaving? Quite a lot of surgeons from the past left too much a bit of the antrum, left too much a bit of the fundus, sleeve a bit too wide. So in those cases, it's not always attributed to the patient that is not doing well. It is more attributed, I would say, it's more attributed, if I would say, to the surgeon that not did a fantastic good surgical job. So on those things, radiology, I think, is imminent. Endoscopically evaluation as well, for sure. Like for a sleeve, is there reflux? If there's something else, I think this is critical. We have to know that for sure. And so on those part, that's all part of the good evaluation of your patients with weight gain. If it's now for sleeve or for bypass, we do quite well the same. And then you can see, together with the dietitian, together with the psychologist, together with the endocrinologist, don't forget the endocrinologist, what you could offer your patient. And we always put nowadays much more stress on what is called compliance enhancement treatment. So we put the patients 3 months on a compliance enhancement if there is no anatomical deformity on the sleeve or the bypass. But in those cases where you can see that there is an anatomical deformity, like a gastric fistula after bypass, or a fundus that have been left too redundant for a sleeve, and patients not a good result from the start, in those cases, we more quickly go to a surgical procedure. But if there is no anatomical deformity, we put the patients, it's imperative, on 3 months of compliance enhancement. Before that, we never go for surgical procedure.
So, excellent message, in my opinion, especially for myself. I learned a lot, and also for our youngsters, this behavioral analysis. So, it's very important. Really, it's a great message. A patient must measure calorie, how much calorie is using. And, sir, for how long time you ask the patient, please write this for 1 month, for 2 weeks?
One week, and they write down everything, also what they drink, and we really beg them to do it very humbly and honestly. We don't have a hidden camera at home, we know, but they know as well. If you explain it very well, it's so imperative to offer a good surgical treatment. Let's say that the patient is eating 4,000 kilocalories a day, whatever. We had some patients after bypass. You do the anatomy, upper GI, and what you can see, there is not a big fundus. There's not a big gastrojejunectomy. So you have that discrepancy between anatomical features shown on the radiology or endoscopy and the clinical reality of having weight gain. A nice study of Abu Dayeh showed that also quite well, where he looked to the measurements of the gastrojejunectomy and look to the percentage of weight gain. What you can see after bypass, when the gastrojejunectomy is evolving to 4 centimeters, 5 centimeters endoscopically measured, then you see a bit more weight gain. But if you look to the scatter plot diagram, you could have patients with a still small size gastrojejunectomy having a lot of weight gain, as well as the opposite. So the patient-related factors still play a very important role, both for weight gain after bypass as for sleeve. And you have to at least do that measurement. And then you still can define, is it more polyphagia? Is it more hyperphagia? A lot of our patients that we see for weight gain after bypass, they are bypassing the bypass again. You understand what I mean? So the minimum is to try to get the patients back on track. If they do not comply, Imran, what we do is that we don't offer any surgical procedure. You can send them to the neurosurgeon to get a new brain, but we don't offer an abdominal procedure. If you understand what I mean.
Yeah. Of course, sir. Really, and sir, how you see the role? Now you have decided to go for surgical intervention. You decided, yes. And how you can see this role of endoscopic role? We can see more and more in future before going to do
I am honestly said, I'm not a fan, but I'm biased myself because I don't have a lot of experience. So I have to be very honest and humble for that. But we have seen quite a lot of endoluminal downsizing for the pouch and the gastrojejunectomy after bypass. After sleeve, it's not quite well known, I have to say. Manuel Galvao Neto is a good friend of me. The guy with the most experience is Christopher Thompson from Harvard University. But if you really look carefully to the publications that have been reported, they are not so, I would say, fantastic. Christopher Thompson has the biggest experience of more than 330 resizing of the gastrojejunectomy after bypass, and he had 8.8% of total weight loss after 5 years, which is in itself not so bad. It's not magic neither, but in 39% of his patients, there was a bias, which he nicely mentioned in the discussion as well, because some of those patients get a second endoluminal treatment, some of those patients got a surgical procedure. He didn't exclude that from his group. So, and they all started with an intensive lifestyle group. So is that 8.8% purely attributed to the endoluminal, I would say, closure of the gastrojejunectomy? No, there's going to be biased as well. So I'm still, I would say, not so enthusiastic about the results, but I'm a bit biased because I'm not an endoscopic specialist. But if you do a surgical procedure, we would not be pleased with 8%, I would say, of total weight loss. If you combine, like for a bypass, a proximal approach with a distalization according to Sugarman, we hope to have substantially better results.
Excellent, sir.
But I think that if the techniques are evolving further, and you have more and more now also surgeons becoming endoscopic specialists. We had Abu Dayeh, I think 1 month and a half ago. We have the nice merit study. You are probably certainly aware for the ESG. We never have seen that type of results in Belgium. But anyway, some results are seemingly okay, good. It could be also good bridge therapy together with the GLP-1s. Why not? That's a huge evolutive field. But for real pure revisions of patients who have gained weight at that serious extent, or they have complications, I still think a bit that the surgical procedure will provide better results. But you have to do that safely, and we can discuss that later. So don't rush on that case. You have to do good multidisciplinary consultation, and you have to have the adequate surgical skills. That's it.
Definite, sir. Nowadays, so a hard talk about magnetic rule. So duodenal and duodenal
Yeah, Michel Gagne. Yeah.
Ghani, yeah, he have started, and definitely he's also a legend, no doubt, and always ideas. And then role of GLP-1 and rise of GLP-1 and anorectic role of GLP-1 and GIP, and definite nowadays
The dual analogs. Yeah, for
we have
sure. I mean,
combination of GIP and GLP-1 like Monjaro and many things. So it proved that when it rise of these hormones is a definite effective, and that metabolic impact of bariatric surgery maybe after 1 decade. I understand when I was a student of medicine, we have no idea about small endocrine role of small intestine, that now we know about this. Definite this so, sorry, my question. So, because in my opinion, this is also a little tricky question about smokers, because also in area that I am practicing, this is a real issue. Still, in here in Middle East and Dubai, the most common surgery is a sleeve gastrectomy. Still, yes, my main practice is OAGB, but still the top is sleeve gastrectomy. Just a patient with weight regain after a sleeve gastrectomy, and patient is heavy smoker. Yes, he asked me, I will, better than hair culture, everything. He will ask, so I will not smoke, but he will smoke. So just now I can think about this, which surgery is better. There is no,
nice.
there is, sir, no GERD in this patient, only sleeve. Endoscopically also, there is no esophagitis, there is no contraindication like for any surgery. So, but 3 4 options. You can go Sadi, you can
For
go for
sure.
OAGB, you can
Yeah,
go for Roux-en-Y gastric bypass, and you can go Roux-en-Y or OAGB with truncal vagotomy for
good.
prevention of.
Nice. And you still also can do the bipartition, the Santoro, which is sometimes also good. But the Santoro is the most ulcerogenic operation because you make, like the Sassi, you make the anastomosis at the antrum. That is for a smoker. I don't think it's the best advice. But I was always say, when you do a bipartition or the Sassi, anyway, I would put the patients lifelong on PPIs because they're going to develop an ulcer. That's not the case, or at least less, when you make a Roux-en-Y with a short gastric pouch. And I think your suggestion to do a truncal vagotomy is a good one. Although if you look to the literature, you don't gonna find a lot of that. But it's not so difficult to do a truncal vagotomy. In those cases, it could be better. But at least, I think, Imran, you have to give the incentive that the patients are gonna stop smoking, or at least lessen the dose. If they don't quit smoking, you have to put it lifelong. And now it's very interesting. The Saudi operation on that part, I think, is not going to be so ulcerogenic. We all know that. It's not because you're already distal from the pylorus. It's still you could have certainly an ulcer, but I'm a bit afraid that the OEGB, if I may say so, on a smoker, but you have more experience in that, it's certainly going to be a bit more prone to develop an ulcer there in those cases, because we all think that the bile will neutralize the acid when it comes there. But a lot of papers, I've also had Rudolf Weiner in the discussion, he has seen quite a lot of marginal ulcer even after an OGB. But it's a nice discussion we could have. I know if you could ask it to Dr. Rutters, whatever they say, we will never see an ulcer. But in clinical practice, it's not always the case, I think. But you certainly can add on that. I don't think that the neutralization of the bile of the acid is giving you the 100% certainty that you're not going to develop an ulcer. I don't believe on that completely.
Sir, I agree with you, because we must be honest and realistic. With all respect to Rutledge, he's a friend's mine, no doubt, and also a mentor. But sir, the reality, yes, we personally, I am facing marginal ulcer not only in smokers, also in,
Even, yeah.
This is the reality. But these are, because why I am asking these questions. I am talking with someone who is the leader of guidelines. Same question from Mario. What was his suggestion? It is interesting. I will share his interview with you. Same
Yeah.
his suggestion, and he's doing, and maybe in coming, if so, he will show the data. he completely do entrectomy, remove antrum to
I know.
decrease gastrin, and then amazing. He is asking, so now marginal ulcer is much less because he's doing OAGB. So just near to antrum, so all this is the pouch, just remaining the small part he removed. So just so
I
what's
think
yeah.
I think that Rothbrunn, but you don't know him, he's a German surgeon. He did already in 30 patients with a persistent marginal ulcer after gastric bypass, a total gastrectomy. Total gastrectomy. Also with the gastric idea, because when the vagus is still innervating the gastric pouch and not going to the distal part of the stomach, it could be too much activated by the gastrin. You understand what I mean? So that was his thinking process. Amazingly studied, but it did not get it published yet. I said to him, when nobody can read it, what is true and what is not true. But anyway, he has a vast majority of those patients. He left the chronic ulcer, he removed the remnant stomach, and nearly all ulcers has healed spontaneously. Could you believe that? By this gastric reaction that they're waiting for. The only drawback, if you have a patient after OAGP or a patient after a wide gastric bypass with a marginal ulcer, and you're gonna completely remove the stomach, that's already an invasive procedure. You never can do an undo of your bypass neither. So that it's amazing that study, but if I have not read its results in a serious paper, we're not going to adapt that technique. You understand? Because if you remove the stomach, it's for the rest of your life. You cannot reconnect it. If you never know that there would be recurrent ulcer, then you have to do an esophagojejunostomy. Stomach is away. We're still talking about relatively young patients. I think it's a bit too aggressive, but your concept of the gastric is a very nice one. It's not a new one, it's a very old one that they've picked up for your idea, but 100% true. But we don't do that yet. If we have a persistent marginal ulcer, and which is refractory to medical treatment, we still excise it and make a new anastomosis. And in some cases, where it was the third one, we do a truncal vagotomy. I don't think there are a lot of drawbacks or I would say complications of doing that truncal vagotomy, but you have to do that nicely, completely circularly. That's I think you have to do.
Sir, as you
But
have
a good
mentioned,
suggestion.
yeah, Helmut Billy also mentioned this in his interview, and he's routinely doing truncal vagotomy. So
Yeah.
because this marginal ulcer is an issue, and if we will not think only we cannot stay on PPI how long time. Again, we know side effects of PPI for how long time patient can take this medicine. We are surgeon. We must think about something.
And the future as well. But I think they will rather fastly gonna die of a lung cancer, of a cardiovascular arrest if they keep on smoking than dying from PPIs. You understand what I mean? It's much better that they would stop smoking for their health than the lifelong risk of giving PPIs. I mean, we have to balance those things. So, but you're right. I mean, taking lifelong atrophic gastritis, etc., for the stomach probably not so good. But smoking is even much worse. So it is better that he stops smoking.
Sir, I have one question. Maybe because I don't know about this, this is the reality. Because we all know the role of vagus
Yeah.
nerve. We all know. So because this is very important, and especially not only in stomach and also in small bowel and branches. When we will do truncal vagotomy, any study, what will happen with the patient?
Yeah, not a lot of problems. We have seen that. Don't forget that the super selective vagotomy was very popular in the 50s and the
I know.
60s. Okay,
Yeah,
okay. But anyway, there were not major problems. And also a lot of vagal nerves branches have been killed. Now, if you do a gastric bypass and you accidentally, traumatize the dorsal vagal nerve, it has no influence because the eventual influence on the pylorus has no importance if you go for bypass. The only thing is, if you do a completely thorough dissection with a vagotomy, yes, then the problems on the pylorus will be problematic if you don't bypass the concept, you see, because the pylorus will become in a hypertonic function. But in regarding of the small bowel and the colon, honestly said, there are not major disadvantages. Amazingly, not.
Because my question was not only stomach, because now when we do gastric bypass,
Yeah,
stomach is just a tube, just like a esophagus. But
yeah, for
the
sure.
role of this vagus nerve, other parts of GI system. So this is my question. Maybe we can talk more about this with the physiologists, because
Yeah,
if we are going to do to standardize a technique for prevention, when we must also see, it is not good. So after 5 years again, oh my God, we did thousands truncal vagotomy, and now we are facing such a situation.
Okay, that's right. Nobody has that experience of 1,000 truncal vagotomies. That is
Yeah,
quite sure.
yeah.
It's just solely if you are referring to Helmut Bailey, I was even not aware that he is doing that. I would still be a bit, I would say, protective not to do that systematically. As you mentioned, we never know what's going to be the influence on the longer term. You're 100% right. But seemingly, he also not is reporting a lot of problems on the level of the small bowel, neither the colon, so or the pancreas, whatever. It has not such an important influence, what I think.
Okay, sir. Thank you, sir. This again a issue because it's
May I just refer to that sometimes, when you do esophageal cancer surgery, I did so many in the past. Yeah, in a lot of those instances, happily we didn't traumatize the nervous recurrence, but the vagal nerves have been also resected, and no influence. So there's a lot of experience already, in doing those vagal resection for esophageal cancer.
But sir, routinely esophagectomy is so about 50, 60 years, and patient may.
Yeah, that's right. That's right. It's
Yeah.
not comparable.
But
That's right.
we are talking with a patient like 20 years old, and just imagine he lived 80 years. So
I
this
think you're right, Imran. That's also the reason we don't do that standardized. I mean, I think it's too aggressive. Yeah.
we must talk about more about this. Sir, a case with intractable GERD, after a sleeve gastrectomy. And
Yeah.
yes, you see patient now lose weight, patient BMI is 22, 23. So we have decided to help because this is also a question from our viewers. There is, because this is a simple question for you, a simple question, but this will be a message for our youngsters. Also migration of sleeve, there is small, also hiatal hernia. What you will do
In
it?
a lot of patients, in a lot of patients after sleep, certainly with GERD, and then you have to reposition that. Evidently, reposition, do a cruroplasty, but then how you get the sleeve fixed into the abdomen, that's a bit strategic, not evident. I was normally never fixing the sleeve on the cruri until I've seen Kelvin Higa doing that. When at the ERCAT meeting in Strasbourg, I said, why? Because you always have 6 or 7 centimeters with the respiration. Why you fix that? He fixed it because he said so much otherwise recurrence of that. So we fix it as well now when we reposition the sleeve to the left crura with one nice stitch. And then you have to decide the BMI of your patient that you say 23, 24, etc. Because the best solution is going for a bypass. I think we all know that, certainly when there's more obesity. But you can still also use the ligamentum teres hepati, that to use it as a sling. I have no experience of the links. I know in Saudi Arabia they're doing it more, etc. So it could be a good solution, but I'm still a bit afraid to put that hard ring, magnetic ring device around yourself. Because if you have a migration, please, that's a disaster. So we try to use the ligamentum teres hepati, but in some cases it's very small. You understand? So it's not easy to make a nice sling around of 360 degrees. If you cannot do that 360 degrees, then you can do that 270 degrees. At least to have some traction that your sleeve remains into the abdomen. But regardless of that, I would fix it to the left cruise as well.
Sir, we can also go for Roux-en-Y with short BP limb.
I'm sorry, that?
Roux-en-Y or Roux-en-Y gastric bypass in this case with short BP limb.
Yeah, that is the best. I mean, what is important, and I always say to the patients as well, if a patient got initial BMI of 40, they had a sleeve with a fantastic result, BMI 23, and then GERD, which is not treatable. I mean, GERD C, D, even Barrett, etc. I'm not afraid to do a bypass. Why not? Because we have to look for the weight of reference. So this patient would not lose a lot of weight, but he will get off his reflux. And if you go from a bypass, when the patients have Barrett after sleeve, in 50% of the instances, the Barrett will disappear. Quite a lot of small studies have shown you that. So I think that the Roux-en-Y, and better than the OGB, I'm so sorry, Imran, is going to be better, that the acid will go down. And I'm not afraid for a lesser BMI patient to do the bypass, because everybody's looking to the nadir weight. That is not so critical. You have to look what is the initial weight. And then you can refer to a short limb BP gastric bypass, the classic proximal one, and the patient would not lose a lot of weight anymore. She or he will be stabilized in weight, but the reflux will disappear. The best chance to disappear for the reflux is indeed converting it to a bypass. And I will say you why, Imran, I'm sorry. It is not always the hiatal hernia or the herniation of the upper part of the sleeve inside the chest, which is causing the reflux. It's also sometimes problems of the lower esophageal sphincter. So that hiatal repair, which we always do, and the reposition could have a good result on the reflux, but it's not going to guarantee you. You have to do sometimes something at the lower esophageal sphincter, which could be disrupted, regardless of the presence of an absence of hiatal hernia. And I refer to that in the history. It's nice to say you that the initial attempts to treat patients for reflux was by Allison, a surgeon in the 40s. He did the choraplasty reposition of the pouch. Results were disapproving. And then it was in 1953 that Nissen evolved his fundoplication, and then suddenly the reflux was much better under control, regardless of the presence or absence of hiatal hernia. If there is a presence, you certainly have to do something, but I have had quite a lot of patients who develop Barrett and serious GERD without the herniation of the proximal part of the sleeve. What you're going to do then? You understand? So it's not, there could be an association between both, but it's not a black and white association.
Sir, excellent, excellent. And another option, just because it will be great. So if your opinion, we take your opinion. In same case, yes, I know standard is Rowan Y with short BP limb, as you have mentioned. But same, yes, we reduce this pouch, we repair that crura, we fix with left crus, and also there is no kink, there is no twist at
Obstruction, yeah.
obstruction. Mechanical, we rule out that. Can we add a loop from jejunum, just 150 from jejunum, to change it SASI to, because then it will be low pressure, and also maybe this loop will help to stay inside, and maybe I have no idea. This is just bias. So, what is your opinion in this case?
Yeah, surely not a SASI. Then you have to do bipartition. The SASI, I think, is contraindicated because of the huge load of bile coming in.
Yeah.
I don't think, I know Tariq Mahdi will discuss, we will counteract that, but it's not true. If you do that, at least do a bipartition, that you do a Y construction, and you make it less. Surely the reflux will be better in the control. But why then not go to a formal bypass? What is the difference to a Stentora? Okay, you have the continuity of your sleeve. If there would be any duodenal pathology that you still have to look for that, that is a good reason. Some cases you had to do so, duodenal polyps, or they have to look for the sphincter of body. That's a reason to maintain that maintenance. But otherwise, the better preservation go for the bypass.
Excellent. Sir, you have mentioned, so nowadays, so one of your routine practice is revisional surgery, weight regain after Rowan gastric bypass. We all know, so this distalization, we know Sugarman standard, everything we know. What is the standard technique of Bruno?
Yeah, that is good. So we really work with a treatment algorithm. I'm not going to show if I can have otherwise here. We have a treatment algorithm that we got published. Can I have in my screen or not?
You have access, sir. You can do.
I'm just going to give it a try. That would be nice otherwise. 1 second. So we work with a treatment algorithm that we got published in 2021. Can you see my screen now? I'm sorry.
Not yet, sir, not yet. So first you must open.
1 second. I just gonna, yes, I opened it here. Here it
Here.
is. I have it here, yes. And then I have to go to yours.
Yeah, click
1 second. Do I have the modality? 1 second. I have 1 second. Wait a second here. Zoom. And here I have to share.
Yeah, when you will click share, maybe we can still not.
No, I cannot share. Anyway, good. We continue it. I'm sorry.
We are interested to see. Just click. So when it will be okay, then click share.
Yeah, wait 1 second. Click share, but I don't see here anything to click share. I'm sorry. I don't have my guys and my girls with me. 1 second.
because we interested to see it.
Yeah, because I think it's interested as well. 1 second. I'm sorry. Yeah, why I cannot here bring that in with Zoom. I have here Zoom. Yes, I have my presentation here, but I don't have the screen on Zoom anymore. That's a pity. I'm sorry. Wait 1 second still. 1 second. Here. Aanscherm delen. 1 second. Okay, now what do you think about that?
Yes.
Now you can see something.
Yeah,
Is that
I
not
can
good?
see.
Okay.
We
You
can
can
see.
see that. Can you share that now?
Yeah, sir.
I'm
We
sorry.
can see.
Okay, very good. Thank you. So, and that's critical, a good algorithm. So when a patient have weight gain after bypass, we do the necessary investigation, upper GI, endoscopy, lab test. The only drawback that we don't have yet is a CT volumetry. I've seen some fantastic pictures from surgeons from Egypt and probably your country. We discussed that with a radiologist. You could not believe that neither in the Netherlands, neither in Belgium, it is readily available, which I think is a handicap because you have a nice volumetry of that. Anyway, when you can see on those studies that there is an anatomical deformity, can you see my mouse here? Yes. Let's say that there's a gastric fistula. There is a big horizontal pouch, as you can see. This was a secondary gastric bypass after primary band. In those cases, when we have an anatomical substrate,
Sir,
which is,
sorry, sir, please maximize the size.
okay, I will
Yeah.
maximize the size. I'm sorry. Is that better?
Yeah, excellent.
I'm sorry. So when we have a patient with like either on the left side, where you can see a big fundus that have been left, and those are most of the time primary non-responders, like from a band, the surgeon was too cautious, then we straight away go for corrective surgical procedure. And we can do very nice procedure. And if I have the time, I certainly can show you a nice video. But in the vast majority, we see that the bypass looks normal, or the pouch is just a bit slightly enlarged, or the gastrojejunectomy. In those cases, when there is no anatomical substrate which is causing the weight gain, we put the patient 3 months on the behavior modification. Now, if the patients do not comply, as I said, no surgical procedure. Now, if they do comply, then we can opt to go for a revision surgical procedure. And then I think it's critical what we do. Then we have measured the caloric intake. And if the patients are eating more than 1,500 kilocalories a day, it's a bit arbitrarily, but we've discussed with some surgeons throughout the world that we are making as the cut edge. When they are eating more than 1,500 kilocalories a day and the bypass looks completely or more or less normal during the operation, we put an adjustable band. An adjustable band. Although we all know adjustable band is that now been abandoned, there's quite a lot of literature supported that. And we, in our publication that we also had in 2021, we had 50% of additional excess weight loss, which I think is very acceptable. And then with that adjustable band, which is not an invasive procedure because the surgeon was not there, we give the responsibility towards the patient to yield the results. So you can fill that afterwards, etc. So we give a bit more responsibility to the patient. And we all know that the quality of life will be at stake, but those patients are eating back again too much. So they're asking now to have more restriction. Now, the vast majority of the patients, when we go for surgical procedure, we see that the pouch and or gastrojejunectomy and or candy cane has been enlarged. In those cases, we do resizing, either a pouch resizing, either a gastrojejunal sleeve, and we're going to put a non-adjustable ring on top of that to enhance, to consolidate that added restriction, because quite a lot of papers have seen if you not put a ring around it, you are prone that there will be back again weight gain, as been shown by Traman Hamdi from the Howard University, Antonio Iannelli from the University of Nice. That's the reason that we put a non-adjustable band. And we're only going to consider to add a distalization for those patients are still quite well restricted. Most of the time, elderly ladies, etc., not doing a lot of physical activities, they are still compliant. They do their best. Now, what would be the purpose, to work on the left side here if the patient is eating 1,200 kilocalories a day? From 1,300 to go to 1,100, that's not going to provide you well. But if the patient is eating 2,500 kilocalories a day and you go to 1,100, then at least you can expect to have better weight loss results. But if we go for distalization, Dr. Abbas, that's important. We never leave anymore 3 meters of total elemental limb length. That is too less. A nice study from Gyasi, Kelvin Higa, Eric De Maria have shown that 3 meters is going to give you too much malnutritional problems. And that's also a bit our experience. When we were doing the Sugarman with leaving 3 meters, that means the sum of the elementary limb and the common or the new common limb, that's 2 less. In a quite a lot of patients, we had to proximalize back again with 1 meter because it was too invasive. So the advice is now, if you're going to distalize according to Sugarman, the distalization according to Brolin never going to work. We all know that if you're going to do the Sugarman, leave 4 meters as total elemental limb length. That's going to still give you good results and not going to be confronted with a higher chance to have serious problems with malnutrition. That is a bit our algorithm.
Sir, excellent, really excellent and definite in this algorithm. There is, sir, my question from this algorithm. So normal Roux-en-Y gastric bypass, what do you mean normal? The size of pouch and JJ?
Yeah, that's good. The size of pouch is, we started a long time ago with the Capella pouch, 7-8 centimeters. Then we went to the Phobie pouch, 2 or 3 centimeters, a bit too short. Now we are in between because we have learned from the OHB as well that the size of the pouch is still going to give you good restriction. And that's true. So we'll leave the pouch at 4-5 centimeters, you see. But what is important, the classic elemental limb is between 50 to 100 centimeters. And the elemental limb is going to be 75 to 1 meter 30. But now we change our strategy. Patients who have a very high BMI from the start, and we still go for the bypass, although you can discuss to go first with the sleeve. Then we tailor that. We have learned that from the OHB. We're going to make a BP leap of 1 meter 50 and an elemental limb of 75. But for the younger patients, we work even more on restriction because we're going to say we're going to put a non-adjustable band on top of the pouch to preserve better the volume and the contour of your pouch on the longer term. Certainly for young patients, at least that we're not going to see that weight gain due to the loss of restriction on the longer term. So what we do for patients with BMI of more than 45 and they're younger than 40 years, we're going to put the ring on top of that. A non-adjustable ring, a minimizer or a mid-cal with 4 different standing. That's a bit our standard practice.
Sir, regarding this, if we see this this gastric band, so you know better than me, there is a lot of side effects of gastric band. So my question, still have you revised any gastric band? When you
we have to revise. And I've just, if I want just second, I come to our study, which we had published here. If you can see that 1 second, I'm not going to go too much in detail. It's just 35 patients that we got. And back again, additional excess weight loss was 50%. But we had our complications, but we changed a bit our strategy. We had 2 patients with band slippages and 2 tube migrations. What is a tube migration? Those are patients where we left the tube too long inside the abdomen and the patient developed a volvulus around it. So if I have just 1 second, I can show you how we can prevent that nowadays. It has been also published by can you see the video? Yes.
Yeah, sir, we
so
can.
You can see, we're going to make a retroperitoneal tunnel to leave that free part of the tube too shorter in the abdomen, that we will never have any risk to have a volvulus or a migration of the small bowel around it. And why is that risk much higher in a secondary band than in the primary band? The reason is very simple, because the elemental limb, as you can see here, have been lifted up anticolic. So that is the region that you have to be a bit more careful in positioning your tube. Now you can see it's a relatively short pouch because we guided it retroperitoneally, also published by Jan Willem Greven. But back again, it is the vast majority of patients, what we do nowadays is a gastrojejunal sleeve. And here, like in a pouch, I will just can show you that just very briefly. And we're going to put then a non-adjustable band on top of that to consolidate, by way of speaking, that added restriction that we try to achieve. Here, very rarely, you can see that we only have to do a pouch resizing. The reason is very simple, because only the pouch have been left too redundant from the start.
Sir, that you're highlighting now, gastrojejunal sleeve. You mean that Roux limb, dilated Roux limb also?
Nice. So that is a good remark. But if you do a resection of that dilated Roux limb, how long it's going to last and where you're going to stop that, you know that as well. It's better to tackle the entrance of the small bowel than the small bowel itself. It's not going to maintain too long. It's better to tackle the gastrojejunostomy itself, that has been proven, than the small bowel. So all attempts to diminish the volume of the small bowel, it's not going to be long lasting. I don't believe on that.
Excellent, sir. Really excellent. And just regarding this gastric band that you put for restriction, increase restriction of this pouch.
Yeah.
Also, you have revised these cases.
Of the resizing of the pouch,
No, no,
very
no.
rarely.
Yeah,
Well, which one you are saying? I'm sorry, which one
sir,
you are?
sir. Because routinely we see migration of this gastric band,
Yeah.
erosion of gastric band. Have you faced such a situation in these cases?
Very rarely, and that's very important. And why is that nowadays? We don't fix the ring around to the pouch itself. No, that's not a good idea, because at the site where you fix the ring on the gastric pouch, that's going to be the locus majoris to have a migration, because it has been fixed with a non-resorber stitch. What we do nowadays, we use the remnant stomach to fix the ring above and underneath. You understand? So
Yeah.
if a migration would happen, it's not going to fix at the outside. So you can easily retrieve that endoluminary, or it will be expelled spontaneously without any major problem. So we don't fix the ring anymore on the pouch for bypass. On the sleeve, however, we have to do, because on the sleeve, we don't have that anatomical substrate of the remnant stomach. But it's better to use the remnant stomach to fix the ring on the lateral border so it could not slip. We don't fix the ring anymore. As you can see on the picture, it was still with on the pouch. We just use the remnant stomach. I think it's better and safer, back again, because if you have a migration of the ring and erosion and it's fixed from the outside, we should all look for the endoscopist to retrieve that, because you're going to traumatize the complex. Where is the ring been fixed by the stomach above and underneath, it is easily retrievable.
Yeah, definite. So, sir, please, if you want to show this video.
Yeah, that is a video where we tackle the gastrojejunectomy. You see here, and in those cases, we even don't put a band, where you see the gastrojejunectomy has evolved to, what is it, I think 5 to 6 centimeters. In those cases, the only thing what we're going to do is a nice gastrojejunal sleeve. It's not a difficult procedure. I will show you that. And when we're going to remove that, you're going to see what part that we're going to remove, and we're going to fill that with carbon dioxide. You can see that here, we may assume that the weight loss results will be very good, yes or no, because the volume that we removed, I think, was excellent. So we don't put the ring on top of that. But I was going to show you sometime, if you still, I have still 2 minutes, that resizing, you still have to be very careful, because we have to know how the anastomoses have been made. I'm just going to show you that briefly. It's interesting, I think, for these surgeons. You have to know how the gastrojejunectomy has been done, because you could have some mistakes if you do that. I'm just going to show you that. If you do the gastrojejunal sleeve and you know that the anastomosis have been made with a circular device or hand sewn, you nicely can do that resizing without any problem. But if the anastomosis have been made with a linear device on the dorsal side, you have that tongue-shaped spur of the jejunum going upwards. You know that, Imran, it's going to be 3 centimeters or 3.5. If you're just going to resize that and you're not careful for the vascularity of the small bowel, you are at risk to have a triangle of small bowel, which is potentially going to devascularize. I'm just going to show you that in a very brief video. We were brave to do that gastrojejunal sleeve, and at the end we could see here that triangle of jejunum. That was a linear stable anastomosis. And then you can think, oh, it's going to be a hematoma. That's not the site of a hematoma. That's the potential site of ischemia. And the first day the patient would not have problems, probably the second day as well. But this patient are prone to have a contained leak or even an open leak. As been published by Ianelli, he had 50% of leaks after that gastrojejunal sleeve. And I think it's attributed to, the fact that you have to be very careful to do that. And also, always excise the old staple line in your gastrojejunal sleeve. If you don't do that, you are prone to leave a small piece. I'm just going to show you that, and then I stop, Imam, because otherwise I will take that over.
No, 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 sir. Excellent. Excellent, sir.
That's not my job, but it's very important. I'm sorry, how you do that resizing. Just going to show you that. Just show you that from a VBG. I'm just going to, that is a VBG. If you resize that, that looks easy. But always, you have to be careful, where is that old staple line? Always look where's the old staple line if you resize, because sometimes it's not completely at the lateral border. It could be a bit more curled medially or dorsally. If you're going to resize that bluntly, and you stay away a bit from the tube, this part could become ischemic. Yes or no? Back again could cause a lot of problems. Also, quite a lot of those old staple lines are more in front. If you're going to do that resizing and you think it's easily done, this part could become ischemic. ICG, I think, is a good tool for that, but use your eyes. In your resection, the old staple line has to be completely, and you understand that well, has to be excised. I'm sorry, just to explain.
Sir, excellent. Sir, excellent. Excellent.
Those are technical details, but I think it's imperative. If you're going to jump into difficult revisional surgery, always you have to balance, I would say, the potential benefit in terms of additional weight or comorbidity control versus the risk of complications. And on that part, I mean, that's what I always say to the young surgeon with us. You have to have advanced surgical skills, use your eyes, you know, and never to be too brave. Pull back on time where you think it's going to be too hazardous, too tedious. It's not a shame to pull back. And it's very important, you know, that we have to know that we do an important job, obesity surgery and also revision surgery, but it's still not like oncologic surgery. It is not like oncologic surgery in terms of survival, not it is acute life saving. So we have to take that, I would say, with some humbleness in our heart.
Sir, so much thanks, sir. Really, it's a definite a great message from your side. Sir, if possible, please stop sharing, then we can see.
Yeah, okay, I'm sorry. Yeah, for sure. I would just, I think.
Yeah.
Good.
Sir, sir, one question regarding GERD after Roux-en-Y gastric bypass. Yeah. That is a very tricky question. Have you experienced a fundoplication in this case?
Yeah, we do quite a lot. It's called the modified Nissen. Why is it modified? Because it's not a formal Nissen, because the stomach has been excluded. It's attributed to Nilton Kawahara, who firstly described that in 2012, and that we think is now the best procedure. And happily, if we have GERD after bypass, there's still that stomach there that you can use.
Yeah, remnant.
And it is not used like a classic Nissen because it's not filled with air and with saliva, but you're just going to bring in a mechanical barrier. This procedure has been criticized by a lot of surgeons. Yes, but what you do, it's not a Nissen. No, we know it's not a Nissen. But if you're going to do a Lynx, if you're going to do a Stretta, if you're going to do whatever procedure, it is trying to make a mechanical barrier. And this is a mechanical barrier made from its own composition. I think it is good. And we have seen good results, but what we see most of the time, we rarely see bypasses with reflux, but in most of those cases, those patients got a band previously or a VBG. And by the long existing higher obstruction of the stomach, the lower esophageal sphincter has been disrupted. And in those cases, we can still see some reflux.
Sir, you recommend in also in OAGB if
yeah. I think for OAGB, that would be good, but that is very important. You have to know what type of GERD you have. If it is acid GERD, and that has been underestimated in literature, when you have GERD, everybody thinks about bile. Jean-Marc Chevalier has now shown that in a study that quite a lot of GERD is still acid. If it's acid, you can do that modified Nissen. But if it's not acid, it is bile, you have to do the conversion to Roux-en-Y or you make a Brown's anastomosis.
Then definitely Roux-en-Y. Sir, regarding this.
But if it is acid on the Tom de Meester score, you can do that modified Nissen, because if you're going to convert it to Roux-en-Y, it could be that you're not going to help the patient. Nobody's making that discrimination. That's very smart. Everybody has GERD after OHB, go for the bypass. Oh, no. You have to know what type GERD you have.
Yeah, definitely. This was my question from Chevalier, I remember. So when he presented this, one of his colleagues presented IBC in Oxford, and this was my question. So have you any endoscopic findings? So this was acid-based or bile-based GERD after OAGB, but they have nothing. They have no document about this, I remember at that time.
No, they documented it now, because on the Tom de Meester score, you can know that. And when you do endoscopy and you are in the proximal part of your OAGB and you see bile, I think they did bilirubin studies on the part of the pouch as well. I don't remember it completely, but they did a nice study to discriminate acid reflux from bile reflux. That was in that study.
Excellent. Sir, my question regarding this, so because you have highlighted, so sometimes we are doing Rowan by gastric bypass after this bending, gastric bending, and due to gastric bending a restriction, we have hiatal failure. So, are you recommend in routine? So, when we are going to do this Rowan by gastric bypass, maybe there will be gear due to this. Yes, we repair that. We can do routinely this fundoplication. Can we do?
We don't do that routinely because I have to say, frankly, the bypass is such a potent anti-reflux procedure that, you know, if you really have to construct that completely. But probably you're right. I don't have any figures of my band to bypasses back again. I think 1,500. That, you know, that when we were doing the conversion to the bypass, that there was a big hernia, yes or no, that we corrected, yes or no. And normally we didn't correct it. But nowadays, you know, it's a bit, I would say, missed opportunity, certainly when reflux would be at stake, that you don't do that reposition of the pouch and do a choraplasty. And you can use that remnant stomach to fix it very nicely to the gastric pouch and the left cruise, that it remains inside the abdomen.
Excellent. Yeah. Excellent. There is no need to do just fundoplication. If just we fix with the remnant pouch, again,
and then I believe me, Imam, it will never re-herniate it. Why? Otherwise, you'd have to grab all the stomach away. So, and we even use 2 stitches. It's an easy procedure. It's nice, but you preserve that the pouch of your bypass remains into the abdomen.
But there is no chance of gastrofistula. Are you put any momentum?
That's a fake story. That's a fake. Why is that also? When you put that with a non-resorbable stitch, I don't believe on PDS. Resorbable is not going to last. You have to be careful that you don't align both staple lines. We take one in front and one on the back side. So the staple lines are far from each other. That is a stitch stomach to stomach. Why would that cause a fistula? Yeah, then I think every gastric plication that have been done in the world, you know, by Talebura, whatever, you know, they have to see fistulas all over the places. That is not the case.
Sir, really excellent. Really, I like to continue this interview because lot of knowledge, lot of wisdom, and still we need your support because unfortunately due to time. So you can't.
Thank you for the compliment.
I think this was just 5 minutes, but you can't believe now 1 hour finished. This was one of the best session, no doubt, and definite for our viewers, for myself. A lot of wisdom, lot of knowledge.
Thank you.
Sir, really so much thanks. Always you're sportive. Any message for our youngsters? Those are quick start to.
I think for youngsters, I would some give advice. Firstly, to things that you don't have to do. That's my personal advice because we build up a strong practice in a competitive country. You know, we have Jacques Kieper, we have a lot of good surgeons in Belgium. I'm proud for that. Still, we have a high volume. I have never been too innovative. You understand what I mean? Never. Everybody, when they see a new procedure, he jumps on that and then he's forgotten the old procedure. No, now I do an adjustable band on top of a bypass. That is even not Mark Besser described that. So I don't jump immediately on the ECG. I don't immediately jump on the gastric plication new procedure. I leave that to the others, because bad results have much more a sound outside than good results. It's a competitive world. There are young patients that we are treating, so we may not forget that. And also, I'm not, I would say, excited to have supranormal results. I don't have to have 100% accelerators or 120% accelerators. The better is the enemy of the good. You understand what I mean? We have to still bear that in mind. And we always have to be humble. That's what I said. Don't do too risky operations. I'm going to say, frankly, there's now a trend to convert for weight gain the gastric bypass into a SALI. Fantastic. I know very good Antonio Torres, Sanchez Pernote, very skillful surgeons. If you as a young surgeon going to start doing that, I would say, Jesus, after whatever religion, that's a dangerous operation. First of all, you have to make your both continuation of your stomach, the gastrogastrectomy. Not easy. I will show you Jacques Kimpens, if you just have 1 second, reported 40% of leaks on the lateral border if you do a sleeve on the same spot. I'm just going to show you that here, 1 second. So if you do your gastrogastrectomy and then you do a sleeve, 40% of leaks have been done. Now assume that you did that successfully. I'm sorry, where are we? If you did that successfully, then you're going to do distal from the pylorus, you're going to do adeno, ileal anastomosis, manual, whatever. Oh, not so easy. You understand what I mean? So that takes 3 to 4 hours. Most surgeons are reported a leak rate of around 20% of those procedures. I don't do that for obesity. I think I have the skills, you understand what I mean? But I think it's a bit too risky for the problem that we are facing for obesity. It's weight recurrence. Taking also into account that at least partly the patient is due to the weight gain as well. We have to be humble. So that's what I would say. Don't ever do also those risky operations, certainly in the beginning of your career, because if you operate somebody and you go from bypass to a SADI or to a dentistry, and you have a leak and the patient is 40 years old, I wish you all luck. And you're working in Dubai, you know that as well. You know, I worked also in Dubai or in Kuwait. It's not going to be easy, you know, to explain that all, you know. So under cancer surgery, if we do cancer surgery, we still have that halo, that umbrella of cancer.
Yeah.
Patients and family accept that. For obesity, certainly it's also your country, come and they think they are healthy. Okay, we're going to do that, it's okay. So they don't accept complications as well, also in our country, because obesity surgery has not still the same extent of seriousness as obesity, as oncologic surgery.
Oncologic surgery. Sir, so much thanks. Really, it was one of the best session, and so much thanks, my viewers. These all sessions were with your support, and definite in future we will continue. This was our 5th interview series,
Okay.
and now we finished our 5th. This is a great honor. So we finished with a really living legend, Professor Bruno Dillemans. That this is great honor for me, and no doubt great honor for me, and finish this session. And we will have in this month last, I will announce this, we'll have a sum up session of revisional bariatric surgery. And definitely in July, we will start complications, and we will talk more and about different complications. Sir, again, so much thanks. Definitely in future, we need your support, and you are always supportive. You are always encouraging with your guidance and support. So we will go and we will continue our journey.
The pleasure and the honor was completely mine. You don't have to say that. Thank you very much. I was very, I would say, enthusiastic to participate again. Thank you very much. And hope to see you in Dubai at the Arab Health or whatever. Okay.
Sure, sir. Highly welcome, sir. Welcome.
Thank
sir.
you.
Thank
Bye-bye.
sir.
Thank you.
Yes.